2, 1. Hello, everyone. We are Group 6, and our topic is smoking cessation interventions in order to help prevent lung cancer amongst the ages of 55 and older in the population of Nevada. I am Diamond Moore.
I'm Zara Bolanos.
I'm Miss Sadia.
I'm in Nature Works.
I'm Alessa Spires. And then
So to start off the presentation overview, the health issue was lung cancer. The population was 55 plus men and women in Nevada, and the behavior was smoking. The theories that were proposed to address the public health problem in the interpersonal level theory, there were the trans-theoretical model and the cognitive behavioral therapy. In the interpersonal level, we had there was the social norms theory, and on the community level, there was the diffusion of innovation. So to start off, let's talk about lung cancer. Lung cancer is the leading cause of cancer deaths worldwide, making it one of the most deadliest forms of cancer. And according to the American Lung Association, every 2 minutes there is a new lung cancer diagnosis here in America. Lung cancer has a very low survival rate of 5 years, and early detection is key to improving the survival rates. But as we go on, we'll discuss why that might be difficult to do. So, what is lung cancer? Lung cancer starts at the lung and can spread to lymph nodes and other parts of the organ through metastasis. There are two types of lung cancer: small cell and non-small cell. The non-small cell type is more common, and so as we mentioned previously, that early detection is really hard for lung cancer, which makes it super deadly, and that is because symptoms do not appear until the cancer has advanced. And once the cancer has advanced, once detected, the treatment options available are surgery, chemotherapy, radiation therapy, and targeted therapy. Sorry, you're muted.
my bad. Okay, so population profile. For our population, we had Nevada, like the area of Nevada. And then for ages, we chose like 55 and older. And then for gender, we didn't specify what exact gender we were gonna look into. However, we did find that males, it's most common in Nevada is 18.8%, and then females is about 14.8% of females who smoke. And then a common thing that we notice for smoking is that they all relate to stress. So when they feel stress, they tend to pop a cigarette. And then I put this picture right here where it says more doctors smoke Camels than any other cigarettes. The reason for that is that because through the 1930s through the 1950s, it was common for commercials to have doctors smoking. And according to these commercials, it's recommended by a doctor to smoke. So I thought it was important because as we're seeing the age group that we're choosing, I think is important because most likely they might have seen a commercial like this, or maybe their parents. So the epidemiological and explanation. So we said that lung cancer is still the leading cause death among people who live in Nevada. About 1,170 people in Nevada will still die of lung cancer. And about 1% of the people who are at high risk of lung cancer have been screened, meaning that about 99% of people have not been screened, whether they're high risk or not. And then on the side here, where we have the little chart, it says rate of new cases are above average. By the way, this is all Nevada right here. Which is not that good for it to be above average. And then survival rate is average, which is a decent thing to know, you know. And then early diagnosis is below average, which is not that good because it's going a route where people are not gonna find out at an early stage. And then surgical treatment is average, which is a good thing. And then lack of treatment is below average, which is not good because once people are having the symptoms, they won't get the treatment that well. And then screening is also below average, which also goes hand in hand with early diagnosis, and they're both below average, which is not well as well. And then to continue off, according to the American Lung Association, the article titled State of Lung Cancer, a new report reveals Nevada was worst in the nation of treatment rates. Lung cancer is devastatingly disease and impacts far too many families in Nevada. So these are some of Nevada's rankings for the lung cancer. So they're ranked 46 of 47. The nation for early diagnosis, the nation is 21.5% and they're at 27.4. There are 43 out of 51 in the nation's cancer screening. 12.3 There are 12.3, excuse me, while nationally it's 16. 47 out of 47 for the nation for lack of treatment. They are 26.7%, while nationally is 20.9. So for the scope of the lung cancer in Nevada, lung cancer occurs primarily in older people. Most people diagnosed with lung cancer is 65 or older. More people are dying from lung cancer than colon, breast, and prostate cancer combined. So some risk factors that come with smoking in general is a chronic cough. We have bad breath as well as bad teeth. It's been studied that it also affects our eyesight and our hearing, and it also has an increase in our heart rate. So, for the behavior overview, smoking in relation to lung cancer, men smoke explains 90% risk, while women smoking explains about 70 to 80%. It is linked to 80 to 90% of lung cancer death, 50 out of 30 times more likely to get lung cancer. And then here we have interpersonal theory, number 1, theoretical model.
So our interpersonal theory number 1 is the TTM model. What is TTM? It's the theory that behavior change is a process that happens over time through different stages. It understands that people need different types of support based on where they are in the stages of the model. There are stages of change. So pre-contemplation is not considering quitting within the next 6 months. Contemplation is thinking about quitting within 6 months. Preparation, planning an attempt at quitting within 30 days. Action is you're actively quitting, and maintenance is that you're not smoking for 6 or more months. The constructs are processes of change, educating through brochures, removing ashtrays in public spaces, and peer groups. Traditional balance would be asking people who are trying to quit to come up with their own pros and cons of quitting. Self-efficacy is building confidence through small goals as like reducing how much a cigarette you smoke each day. So application of this model in an intervention would probably look like pre-contemplation is mass media, like they will have flyers with the title Nevada seniors turning 55, quit now, live healthier. Contemplation is just talking about the risks of smoking and the benefits of quitting. Preparation, just give out quick kiss, brochures, one-on-one planning sessions, action and maintenance. You would just have peer support groups. We worked hard and track their smaller wins as well, not just the big ones. Why is this applicable is because change is not linear, so change is not always in a one direction. There's different stations to it. Interventions are able to be stage matched, so it's more effective. The rationale for choosing TDM is tailor interventions based on the individual readiness to change. This allows for a flexible approach, which is understanding of their history and their barriers. Measurability is change, stages of change, self-efficacy, and processes of change can be measured through surveys. Strengths and limits of the model. The strengths is allow for change over time. Is more personalized to depending on that person and what stage they're in. The limits, the stages can feel strict or unclear. Not everyone participates in one stage. People often move back and forth or relapse. That's very normal.
Okay, the interpersonal theory number two, cognitive and behavioral therapy. Okay, CBT is a psychological concept which focuses on how a person thought process shapes their behaviors and emotions. Um, sorry. Also, it's widely used in therapeutic environments to assist people identify and change in maladaptive patterns. For example, like stress, which is a trigger of mostly unhealthy people, that's cognitive behavior that can result with individuals 55 and increasing their risk of serious health risks such as lung cancer. CBT can assist aging smokers in counseling settings. Okay, when I think of the five stages of CBT, the behavioral therapy stages, and how they apply to quitting smoking. First is assessment of engagement. I imagine basically sitting with the therapy or health educator, talking about smoking habits, stress levels, and thoughts about smoking. This stage is about building trust and understanding the problem completely, without truly understanding why they smoke and plan to quit would be incomplete. The second one is formulation. Medical professional and the individual work together to create a plan. Basically, it's coming with a partnership. They would identify triggers that would like loneliness or boredom and understand the thoughts connected to those triggers. For example, smoking is the only way that they could calm down. Um, so basically, they have to reframe their thinking, their mindset. The next one is active intervention when a medical profession helps the patient with treatment and or rehab to prevent lung cancer and overall health outcomes. Such as smoking, this is meaning that their coping skills to replace smoking, such as relax techniques, as in yoga, exercise, or just therapy, mindfulness, or even simple habits like drinking water or chewing gum or engage in activities, like different activities, if they're craving for a cigarette. And aging smokers, they could do interventions like rehab, improve breathing, and strengthen overall health outcomes. Next is maintenance. Patient practices strategies that help them to avoid smoking again and also prolong protection from lung cancer. They would practice every day they just heavily maintenance themselves. Maintenance as in they could call a friend or write down their feelings in a journal to maintain being smoke free, is being capable of still avoiding smoking and prolonging protection of lung cancer as well. The last one is finally there's termination or evaluation. Health educators assess smoking interventions could reduce lung cancer among patients. Uh, it would help reduce smoking or help. They would think like, oh, the therapy would help reduce the smoking or help me quit entirely. It's not a failure. It's a chance to learn what triggered me and what strategies I need to strengthen. And here are some videos on how these stages of CBT work. So this one is phase two, quitting, and it shows, thank you.
One, managing smoking triggers. Once specific cues for smoking have been identified, you will actively break the links between these triggers and smoking in the following ways. By avoiding these triggers, by changing your daily routines, and by substituting activities in place with smoking. For example, before your quit date, you will want to remove all smoking related paraphernalia such as ashtrays, lighters, and cigarette packs. This will help turn a smoker's home into the home of a non-smoker, which will reduce the availability of smoking while also reducing the number of triggers for smoking. You may also want to avoid high-risk situations for smoking. For many smokers, this entails avoiding drinking alcohol, going to parties, or socializing with other smokers. It will also be important to change your daily routines in order to break the automatic links between daily activities and smoking. For example, you may benefit from taking a different route to work, changing the location of your break while at work, or altering your evening and wind down routine. Two, medication. Pharmacotherapy is an effective option to help reduce nicotine withdrawal symptoms after you quit. One of the strongest predictors of relapse is the intensity of your urge to smoke. Six, medications like the nicotine patch deliver a safe and controlled amount of nicotine to your body, so you can reduce the physical aspects of your addiction while you utilize CBT techniques to address the psychological effects of the habit. Three, helping with triggers after quitting. No matter how much you prepare for quitting, you will likely experience smoking related triggers at some point after you quit. One,
Okay, so the strengths and limitations of CBT boosts self-esteem. Actually helps, that's one of the strengths, by changing negative thoughts, and also empowers people to believe in themselves when their ability to change. Teaches coping skills. Also can be used not only to quit smoking, but also to manage other challenges in life. Third is encourages self-reflection and awareness. Be aware and making yourself more mindful of your thoughts and behaviors each day. So just encourage yourself and just self-reflect on everything that's been going on that would make you be stronger with smoking, so you can avoid having lung cancer and um, yes, and empowering. You can empower people the tools they need to improve their own lives rather than depending entirely on others. So it's empowering, effective for a variety of behavioral health conditions. It can help with anxiety, depression, addictions, likely smoking, and many other issues. Another strength is that it is usually a short-term approach, which makes it accessible and practical for many people who may not be able to commit to years of therapy. Also, a lack of focus on interpersonal relationships, caregiving, workplace, sibling rivals. That's a couple of others, such as these relationship issues can be major sources of stress that contributing to smoking. But behavioral therapy might not address them deeply enough. Another limitation is this CBT is unsuitable for complex mental health conditions like PTSD, where trauma-focused therapies might be needed instead of provided deeper healing.
And with that, we'll move on to the interpersonal level theories. So the theory suggested for the interpersonal theory was the social norms theory. So what is the social norms theory? The social norms theory explains how social norms, which are a sets of expectable expectancies in a group, so that means what is right and what is wrong, what's considered as the normalness in the group, um, dictate how a person perceives certain behavior. The social norm theory in general states that an individual's misconception of these norms shape their behavior. The idea of social norm has been studied since early sociology, but it was first suggested as a public health intervention in 1980s by Alan Berkowitz and H. Wellesley Perkins in a study conducted and based on their research conducted at Hobart and William Smith College on alcohol use. The social norms theory construct has two main constructs, which were drawn from research by Cialdini and his colleagues. So the first construct is descriptive norms, which is beliefs of an individual's belief of what others do. And the second one is injunctive norms, which is the individual's belief of what others approve or disapprove of. So the difference between them is that the first one is the action, so behavior, and the second one is approving or disapproving the behavior. Um, Furthermore, like explaining the constructs, so addressing the descriptive norm and injunctive norm um, causes to it serves to change pluralist ignorance, pluralistic ignorance, which is the individual's false belief that most of their peers behave or think differently from them, when in fact, that is not true. False consensus, which is when an individual believes uh, that others are like themselves when they are not. So, for example, someone who smokes heavily might think that their peers or their group also smokes heavily when that might not be the case. And because they think that way, it might cause them to continue doing that. And false uniqueness, which is an individual's belief that they are in the minority and they think the difference between them and others, themselves and others, is there's a large gap in the difference between themselves and others. So, for example, someone who might be who might be working towards smoking cessation might feel that they're alone in this, they're the minority, and that others around them are not doing this. When that misconception, so these are all misperceptions that the social norm theory tries to address, right? So they might feel that they are alone in this and they're the only one doing this, they're the minority, and there's a large gap between them and their peers, when in fact maybe their peers are also trying to quit smoking. There are more that people like them as well. So that's what the addressing descriptive and injunctive norms serves to change all of these misperceptions in order to achieve the behavior. So social norms theory applied to smoking. So why the reason this theory was suggested, because it's been previously successful in alcohol and tobacco use intervention. So like mentioned before, like descriptive norms. So because it targets descriptive norms and injunctive norms, like in terms of descriptive norms, maybe it can target The individuals believe that maybe their peers smoke more often than they actually do. And because they believe that their peers smoke more often than they actually do, they might continue to do so as well. And it targets injunctive norms, which can be an example. An example can be that an individual might believe that smoking is approved by their group. Maybe they've seen their family do it, their friends do it all their life. Since we are talking about the 55 age population, that it might be something that they see as normal and approved of by those around them. So targeting those norms is one of the reasons why this theory was suggested, because changing norms can lead to change in behavior. So in previous applications of this theory, while it has been popular in the college and youth intervention population settings, it can also be applied to adult as well. Just mentioning that before we move on to the study. So this study was conducted in Canada. It's a study. The study is called "Social Norms of Alcohol, Smoking, and Marijuana Use Within a Canadian University Setting," and it compared alcohol smoking and marijuana use on Canadian campuses compared to American. So the study found that the perceptions an individual had predicted whether they would use or not. So if an individual predicted that perceptions were positive, then they're likely to use the substance changes, versus negative. And it also found that the more misperceptions an individual has, the more likely they're to use, which is what the social norm theory is suggesting as a whole. So how is the social norms theory measured? It can collect data both qualitative and quantitative data. One of the most used techniques for measuring the constructs is by using self-reporting questionnaires. An example of those reporting questionnaires is the drinking norms rating form, which which asked individuals to talk about their perceptions of how others around them of how much alcohol others around them are drinking, and using that, the researchers were able to identify whether their perception led to what behavior they committed. So let's move on to the strengths and limitations of the social norms theory. Some of its strengths are that it has been successful in alcohol and tobacco intervention, as mentioned previously, and it has been recognized and funded by federal, state, and local agencies. Some of the limitations are that critiques have mentioned that the theory is difficult to replicate, meaning the interventions are difficult to replicate, meaning the same intervention cannot be, it's hard to apply to different population and different health topics. And another critique was that because the self because the social norm theories relies heavily, many of the studies rely heavily on self-reporting, there is a question to the skewedness of the interventions. Since when self-reporting, an individual might be compelled to report characteristics or ideas they perceive are socially demanding or socially acceptable, rather than what they actually feel. And that concludes the social norms theory, and we will move on to the community level theory next.
Alrighty, so as mentioned, our last theory is at a community level, being diffusion of innovation. So what is diffusion of innovation? And it is or was developed by Everett Rogers. So it's basically the process or idea of a behavior or product in which gains momentum and also diffuses through a specific population or a social system over time. So the four constructs of diffusion of innovation are innovation, communication channels, time, and social systems. I did input a image of basically like the type of innovators, and I'm going to talk about on the next slide. But for this one, a little bit about the four constructs. So innovation basically refers to anything or anyone who are perceived by an individual or a group, including ideas, practices, or objects, communication channels. This basically means that information about the innovation, like how it's being transmitted. So whether it's through like a mass media, and a interpersonal channels or electric communications, time. So it's pretty self-explanatory. It's just basically the duration of the innovation decision process, the relative earliness or lateness of the adoption for the behavior. And then also it's the rate of adoption within the social system. And then lastly, social system is basically just like the context within which like the innovation spreads, including like the structure, the norms, and then also the leadership. Okay, so referring back to the picture, the image previously shown on the slide, this is basically a breakdown of the adopters. So basically, Rogers developed and categorized the individuals within the social system into five groups. So the five groups are innovators, early adopters, early majority, late majorities, and then the laggards. And then it's basically based on their attitudes toward the innovation. So the innovators, they're the first to develop an innovation. They're usually, head on, ready to conquer. The early adapters, typically knowledgeable about the innovation. So whether it's like little knowledge, a lot of knowledge, is just, they have knowledge on the innovation, and usually technology savvy and financially well off. Early majorities, they adopt cautiously, preferring to see the proven success before committing. So they like to see how it affects other people, what it has done for them, and then proceed accordingly. The late majorities, they're skeptical. They do adopt after the majority has done so. So it kind of ties into like the early majorities because it's more so like a see, like what's how it affects that person, and how they can, what they can take from it to apply to themselves and then move accordingly. Lastly, is the laggards. They strongly resist adoption. They aren't skeptical. It's just high resistant rate, often remaining non-adopters due to limited resources and low awareness. So all falls back to having knowledge on the innovation. And then also it's kind of like a not wanting to receive that because again, they are resistant when it comes to the innovation. I'm sorry, the innovation. Okay, so basically, innovation and focus, just to break it down, smoking cessation product tools. So the prescription-based products, varsarinine, varsarinocline, sorry. It comes in a pill form. It helps cut out cravings by acting as nicotine on the brain and not actually containing any. So it basically seems like the receptors to the brain, like, hey, nicotine, but it doesn't actually have it. So that way the body won't crave like the actual thing as much due to that pill. Um, the next one is bupropion. It also comes in a pill form. It blocks the nicotine receptors to the brain, so it makes it to where you're not actually craving it because of the pill. That pill doesn't have any nicotine in there. It doesn't act like nicotine. It just simply blocks the receptors of the brain. A few over-the-counter based products. We have the nicotine nasal spray. It's as such, you just put in your nose and you sniff it. It basically allows for the nicotine to be absorbed through like the lining of the nose and also into the bloodstream. With that one, you can spray it or sniff it however often, like if you have a craving or anything like that, like just sniff it and it will help over time. The nicotine patches, it's like a little Band-Aid type that you put on your body. And it also provides a steady dose of nicotine with it comes with 3 different types of doses and can also be reduced over time. So obviously if you need a little like higher dose, you can use the higher dose patch. If you need something like not too high, but not necessarily low, the medium, the middle one, and then also the last one, if you don't really need that much of a dose, then you can use the smaller dosage. Um, the lozenges, they're candy-like. They do dissolve in your mouth. Um, it releases a little bit of nicotine as it dissolves inside your mouth, and it also reduces the temptation to smoke. So although you still are getting the nicotine um, from the candy-like product, it still helps to reduce the temptation of actually smoking. Um, Lastly, we have nicotine gum. So with that one, when I did research, it was basically described as like a chew and park technique. So what it is, it's like regular chewing gum, but instead it has like that nicotine in it. And then you chew it until you feel like that tingly sensation. So what park and chew is, so you chew it. Once you get the sensation of like the tingly feeling, that's nicotine being released, and you go ahead and park. So you just leave it in your mouth. You can put it on the side of your mouth, under your tongue, whatever is comfortable for you. And then yeah, you repeat over and over. And it is advised that you go through the pack, so obviously the higher that you are craving the like wanting to smoke, chew the gum. You can go through 2, 3 gums and it's not super harmful for you. It actually will help, to not get that urge to smoke. Okay, so a few barriers to cessation product tools. Um, so there are ways to receive support as far as the products. But it is important to individuals to maintain the attempts to quit smoking. So a lot of products will, as mentioned, still provide that nicotine. So your body will still crave it, but other products will either block the receptors to your brain or it will um act as nicotine, but not really releasing nicotine, just however you choose to go to the products. However, it will help to not get like that urge to smoke. However, it is important to follow the um like the recommended dosage or like the recommended products so that way you can effectively use the product. So the barriers include but are not limited to lack of knowledge, lack of time, and lack of perceived motivation to quit smoking. A lot of people, for example, they have like the products where it releases nicotine. They still getting that fix. So they're, of course, they're still going to go ahead and keep using the products and eventually turn back to smoking. Rather, products that don't have the nicotine at all and act as nicotine, they're eventually over time will cut out the nicotine altogether, not even think about smoking. So that's when the barriers come to play. Just having like that lack of knowledge or feeling like, okay, you say you want to quit smoking, but then, that's when lack of time come in and it's like, I want it done tomorrow. I want to stop smoking. And then you feel as if, you're not able to get through the process. So you go ahead and revisit smoking. So it's not, as effective. And then just lack of perceived motivation. If you have people around you who don't support you or if they're smoking as well, it's kind of hard to cut it all together. So just like that motivation, just having support to, feel motivated to go ahead and follow through. And I did provide a graphic on basically like the thought process. So everything plays a part into, the barriers of the cessation. So it's, thoughts, behavior, physical sensations, emotions, everything. That's why the arrows are basically pointing like to each other because one, you can't have one thing without the other. It all ties back and it does a 360 basically with all those different what do I call them? All the different categories, basically. Okay. And then next we came up with a theoretical framework, basically describing how all of the constructs that we'd use would come into play as far as creating that graph for the intervention. So how can these theories suggested create a framework for interventions? So by combining the theories, as mentioned, the trans-theoretical model, cognitive behavior theory, social theory norms, and diffusion of innovation, it's basically we use those theories to create an intervention in which would convey how an individual operates at a community, interpersonal, and individual level so that the interventions are able to make it easier for adults who are aged over, I'm sorry, who are aged 55 and over to quit smoking effectively.
And here's the diagram we came up with using the constructs from all the different theories suggested. So we pulled constructs from the trans-theoretical model, cognitive behavior theory, therapy, social norms theory, and the diffusion and innovation. First, and created a stage model of sort to work towards improving smoking cessation outcomes of adult 55 plus. So the first construct we took from the social norms theory was the descriptive norms, addressing the norms and belief that an individual has and changing that mindset. So changing the mindset that not everyone is smoking as much as they think they are, as much as the individual thinks everyone around them is smoking. Changing that mindset and getting them to the thought that, you know what, like there are so many other people not smoking. So it's not something that is a norm that seems to be, right? And then for correcting that norm, that belief, and then moving on to contemplation, which was pulled from the trans theoretical model. So in this stage, the person would be contemplating whether they want to quit smoking or they don't. So if they decide they do want to quit smoking, then we can move on to formulation, which was pulled from the cognitive behavior therapy. So in the formulation stage, a medical professional and the individual will work together to create a plan. So rather than the individual coming up with something themselves, right? So we're working with adults 55 plus. These are people that might have been smoking since they were very young. So they have a habit that might be tough to break. So it's important that they are working with a professional. They have that support and they have someone to guide them and come up with a plan together with them, because if someone has been smoking for a long time, it might be difficult for them to find a place to start. And then from formulation, we move on to action. So now with the support of the professional and with the plan, the person can now actively work towards smoking cessation. And while they're in the action phase, which lasts for around 6 months, this was also pulled from the trans theoretical model. During those 6 months, we can have active intervention and introducing innovations. So, active interventions pulled from the cognitive behavioral therapy suggests that a medical professional will help with the treatment and the rehab, right? So during the action phase, this could be like the medical professional or the professional is um, continuously checking up on the individual, checking to see if the plan is working out for them, adjusting to their needs, um, and being there as a support and a guide to help the individual throughout the action phase. And the innovation, which was pulled from the diffusion of innovation, will also work in this stage together. So that means address like introducing the individual to products that were mentioned in the previous slides, such as the nicotine patches, the nicotine nasal sprays, to help them with the withdrawals they will experience during these action phases. So that's the reason why these two were put together, since they go hand in hand, since the intervention will include the innovation. Maybe the professional is suggesting like, oh, this isn't working out, let's try this, we can try this. And after that, we can move on to maintenance. which now that the action has been going on for actively for 6 months, now they're at a maintenance state where they are continuously still working towards smoking cessation, and they plan to do so for the upcoming months. And once they're at that stage, we can now be at a place where we have improved the smoking cessation outcomes of adults 55 plus. And also, it's important to mention that even in the maintenance stage, the individuals should be in contact with the interventionist who are helping them out to make sure, since we're dealing with the adults 55 plus, to make sure who, as previously mentioned, might have been smoking for decades, like since they were 20 or before, right? So it's harder to quit, to make sure that even at the maintenance phase, they're still getting the support they need. So, yeah, with those constructs, the hope is that after finishing all these steps, then the individual will improve their cessation outcomes and quit smoking overall. And that concludes our presentation. So, in conclusion, with the all four of the theories suggested, targeting all the different aspects, we can work to improve smoke cessation in our age 55 plus in Nevada in order to prevent lung cancer risks.
Thank you.
Thank you.
Thank you, guys.
Thank you.